Thank you so much, respected Padam Shri Awardee, Dr. Titiyal sir, Anuga madam, and respected judges, Dr. Bhalla sir. So I'll be speaking on the multifocal IOLs with a retinal problem. I'll not go into the much details about the multifocal IOLs. You all know it very well because they are discouraged. They are especially in patients who are having diabetic retinopathy or macular degeneration or epiretinal membrane or many and so. So let's look into some of these. Use of dark adaptation to screen before the multifocal IOL implantation. So what does it mean? Identifying the patients with early AMD is necessary to avoid suboptimal surgical outcomes. Yes, this was first reported 2014 in ASCRS. It's called as the Maculogics, and the test is easy for the technicians to learn, and it can detect subclinical AMD at least 3 years earlier than it is clinically evident. Now coming to the literature, cost effectiveness of preoperative OCT in cataract evaluation for multifocal IOL, I think there is no question, no debate, no controversy that OCT has to be done, preoperative OCT has to be done in any cases who are undergoing multifocal IOL. But looking into this, they say that the quality over the time has improved when you do a pre-op OCT. The adjunctive screening OCT can be cost effective from a third party or some societal perspective is what is there. Conclusion. Now coming to the cases, 61-year-old software engineer, bilateral drusenoid PED with right eye multifocal IOL. What do you want to do for the next eye? You know that there is plethora of lenses and you people know about the lenses much more than me. I'll not go into the detail, but which IOL to choose? Now IOL selection for patients with age-related macular degeneration, definitely the stage of the disease. If the patients without clinical evidence of macular disease, that means for having any drusen or pigmentary changes, they are almost like a normal patients. Hence, they are candidates for all IOLs. But patients with soft drusen, pigmentary changes, they are not absolute contraindication, but like to say difficult counseling. You need to talk with the patients whether this is going to happen or in future they might develop. Now coming to this last part is patients with moderate to severe AMD, that means who already have a large drusen, confluent drusen, geographical atrophy. In those cases definitely it would have a deleterious effect and better to avoid multifocal IOLs in this case. So next coming to, would you like to implant a multifocal IOL in the patient with age-related macular degeneration? Look at this, the review, they say that they are losing their independence and their ability to read. They are no longer able to drive, to engage in activities. Several articles have listed depression as something not uncommon among the patients with AMD having with multifocal IOL. So these are some of the reviews. Now let's look into what's the life expectancy of a person in India. It is around 70 years. Okay. So now let's look into the demographics of wet AMD and geographical atrophy. Up to 80 years, it is just 2.2%. Whether it is wet AMD. Look into geographical atrophy, up to 80 years it is just 1.8%. So why deprive 98% of the patients with multifocal IOL? So that's again a debatable question. Now, short-term outcomes of combined pars plana vitrectomy for epiretinal membrane phacoemulsification surgery, and they have said that it's fantastic, multifocality was achieved and the final visual outcome was delayed, but definitely there was a macular healing. Now scenario 2, if there is a wet AMD in a patient who has a multifocal IOL, now what next? Not to worry, there is plethora of anti-VEGFs available now in the market. Now we even have a 3-month, 6-month refillable implants for the, so early detection is definitely the cure. Early detection of these AMDs is definitely the line of the treatment. And now we have come into the home-based OCT as well. That is called as a Notal Vision AI. So they give the OCT at your home and any variation or detection in your AMD changes, characteristics or fluid activity directly pings the doctor. So these are the advantages of having the artificial intelligence in your home as well. Now this was very nicely published. AI Notal Analyzer successfully tracks exudative AMD disease activity. Now coming to the last scenario, scenario 3, which needing surgical attention. Yes, that is what is the controversy about, right? So the retinal surgeon says, no, there is lot of this thing, you should not do a multifocal IOL, the laser becomes difficult, the surgery becomes difficult. Now let's look into it. Diffractive multifocal intraocular lens interferes with the intraoperative view, right? So let's look at they have described it as arc-shaped image, ghost image, that image, this image. Definitely it used to cause, but now with the wide angle visualization system, it doesn't happen that much. So what they have published in this, how you can get through it, put a viscoat on the anterior surface of the IOL or the posterior surface of the IOL so that you can get away with these aberrations or these ghost images. Now you can see here, this was what a multifocal IOL through wide angle lens, and then after putting a viscoat, that there was a clarity in doing a retinal surgery. Now retinal detachment repair through multifocal, overcoming the visualization challenge. So let's look into this, my own videos. I have collection, but I'll just show a sample video. This was a case of multifocal IOL with a retinal detachment. Now please look at this video carefully and let me know where there is a hampering of the visualization. Although this was done under 3D visualization system, now you can see there's the patients with a bad PVR. I could remove the membranes over the disc very easily. I could even do a retinotomy in the periphery and then try to remove even the subretinal gland, biotic glands also. Now look at the periphery. Periphery is also equally well visualized. So yes, definitely there are techniques how to overcome these things. And this is the one last slide I would like to say. My senior colleague, who's a friend of my mentor, Dr. Wai-Ching Lam, was published this. We did an instruction course in APO as well. Multifocal IOL, intraocular lenses and retinal disease. He said that they were unable to find evidence suggesting that patients with macular disease should be advised against multifocal IOLs. Several indications retinal disease have a hypothetical character and are not evidence-based. More research is needed, especially to address the effect of multifocal IOL on visual functions, contrast sensitivity, and the patient activity, orientation, mobility, and various retinal pathologies. So definitely, again, it's between the patient's perspective, choice versus the small risk of 18% versus the surgeon's point of view. Definitely we can overcome a lot of these, even in case of doing a lasers or the retinal surgeries. Thank you very much for the patient listening. Thank you, sir.
Dr. Srinivas, Dr. Shakya, are you ready? I think at want of time, just one
Sure.
thing. Today with EDOF lenses, there is a less risk of reduced contrast sensitivity. So these patients, maybe we can recommend that instead of the
No, I am recommending
regular,
multifocal only.
diffractive lenses. Dr. TT.
Definitely. See, my own concern is you do not have to get deprived of these patients of any of these extended depth of focus or multifocality just because the patient has a drusen. So definitely you need to characterize, and with the advance of these newer OCTs, you can even know what is the size of the drusen, what is the size of the RPEDs, and all those things. So based on that, we will give it can give an estimation that how many years he can go in for the retinal pathology. So that's the basic idea. Thank you very much.
So Srinivas, in wet ARMD and Garrett atrophy, there you are not going to recommend.
Yes.
So, and what about the patients who have a lot of soft drusen and pigmentary changes, who are going, do you think they are going to
Okay, I will not take
That's
more
what
time.
that's why we have put it into the difficult counseling. They are not an absolute contraindication, but definitely it's better to watch those OCTs for a few years and then decide.